I want to introduce myself. I'm Cathy McDonald, and I've had the privilege of working for over 20 years well, tobacco work for more than that, but specifically working with Alameda County around tobacco um, training for people in both mental health and primary care. And currently, I'm retired, and the program is being led by Alex Hay, Patricia Sanchez, and Dr. LeBega. Um, but I want to tell you a bit about what we've done and how things worked, and what perhaps might be useful in whatever setting you're working in. I hope that as a result of this, you will be able to identify 4 key elements of tobacco treatment training for primary care and behavioral sites, and learn 3 ways to get the attention of your trainees, and also be able to identify 4 ways to collaborate with training sites to optimize changes in tobacco behavior at those sites. We'll go through a little bit of the evolution of the program that I was involved with, as well as both with behavioral health and later with primary care. And then we'll talk about a basic format for primary care training and adaptations for behavioral health, and some challenges and successful strategies. So what you see currently is the mapping of the beginning of the behavioral health program. And hopefully you can see down at the bottom that we started back in 1998, funded by tobacco tax, later by master settlement, the tobacco master settlement, because our county received master settlement funds. And after 10 years of being funded for behavioral health care and primary care in behavioral health, the public health department said, okay, we've done this 10 years, we're not doing that anymore, we'll keep funding primary care. But we, working with the county health department, asked them to continue the funding, which they did, which was a real win. We're very blessed with that. And a lot of it had to do with the fact that when we started the tobacco settlement funding in the year 2000, the county had the wisdom, guided by the tobacco control program, to tie tobacco policies to tobacco settlement funding, and behavioral health care received a lot of that funding. And as a result of that, had to develop some tobacco policies, which led to them working with us. We had already been working with any interested agency around implementing, specifically at that time, tobacco-free policies in behavioral health care, specifically in substance abuse programs. And the county provided us with a liaison at that point who helped us through to work with a large bureaucratic system which funded over 150 different agencies providing health, behavioral health. And we were able to engage the director in doing a presentation related to the work that we were doing. We provided her with a lot of information. I think that was very helpful. And then we hitched our wagon to initiatives that were coming along, one of which was the 10 by 10 campaign for the country to reduce by 10 years the 25-year mortality gap for people with serious mental illness. And a later one was just for the county, which was the county's tobacco co-occurring initiative, but we were able to build tobacco into that initiative that was being undertaken to join substance abuse and mental health, so that every agency would ideally be able to provide co-occurring resources and point out that tobacco is the most common co-occurring condition. Throughout this period, and this only goes through 2012, although the pattern continued, we started with the teen drug treatment program, which was residential, where I worked, which had already done a lot of tobacco work, which is the reason that I ended up in leading this group. That agency finally went from being tobacco-free for clients, which is not wise, to being tobacco-free for clients and staff. And then this rippled out to a lot of other agencies. Not all were successful when they tried the first time. Many tried again and were ultimately successful. And while all this was going on, there were significant national events going on, like New Jersey requiring all their residential programs to be tobacco-free, substance abuse programs to be tobacco-free. And later in 2008, the Bible of Tobacco guidelines came out, led by Dr. Fiore. And also at that same time, New York implemented a program of treating tobacco on a par with alcohol and drugs throughout all of its substance abuse agencies. So we tried to work on following what was going on nationally and train on that as well as things went along, including training on the new Substance Abuse and Mental Health Services Administration tobacco policies for substance abuse treatment programs and guidelines for clinicians. The activity that we did related to primary care was a little bit different, but again, started in 1998, actually with pediatric training. And we did grand rounds at a local children's hospital, worked with another agency on tobacco as a vital sign in adult clinics, and provided the medical part of the training that they were doing on this throughout all of the clinics in our county that were serving low-income clients and ultimately becoming QHCs, or federally qualified healthcare centers. We continued to work trying to get the pediatric hospital to implement some comprehensive interventions, and eventually that did happen. Meanwhile, I became trained as a tobacco treatment specialist and also as a motivational interviewing network of trainers, assisted in getting the local hospital to be tobacco-free and the county hospital to be tobacco-free, wound up getting a CEASE project funded by a grant in collaboration. Actually, it was a grant that the Children's Hospital finally put in after struggling to try to make something happen with pediatric patients, and was able to implement this project, which meant that the parents who smoked were routinely offered nicotine replacement by the pediatricians and referred through the fax referrals at that point to the helpline. And that resulted in 400 interventions over the first year in their ambulatory services. And later, we began to provide small grants from our funding to some of the FQHCs to try to devise appropriate tobacco interventions in their clinics, with the idea they would eventually no longer receive funding and continue the interventions. It wasn't until 2013 that the pediatric hospital finally became tobacco-free, as you'll know, much later than the adult hospitals. And we assisted in that effort. Then in 2014 and 2016, we kept piggybacking on other projects that were going on. And at this time, we were able to piggyback on a project that involved putting direct messaging into the what at the time was next gen electronic medical record, and making it possible for the primary care clinics at one site to be able to refer directly to the helpline through direct messaging. This was ultimately disseminated to other clinic systems. And then in 2017, I became trained to be a TTS trainer using the UMass format, and trained 15 existing staff in the community working in behavioral health or primary care on a yearly basis since then. Then in 2018 to 2021, the current staff of the program has continued to do the work, and all of those staff have been trained to be tobacco treatment specialists. And now what's happening is that all of the FQHCs have shifted from NextGen to Epic, which, for those of you who know, and it was alluded to by Dr. Fiore, it's a major mass massive effort to get direct messaging into a new EHR. And so that kind of slowed things up. Things had to be shifted around. So that's to give you a bit of an idea of the work that's gone on over a number of years with our program. And we've had the good fortune of continuity, which really does help in a number of ways. And of a small operating team, which I'll share with you details later. So if you're about, we're going to shift gears now and talk about how one might go about doing training for an agency that's a primary care agency. So first, you've got to talk to the agency, see what they're actually doing and what might work for them. And my own thinking about this is that a very wise place to start, if we're operating in a county, is with the FQHCs, the federally qualified healthcare centers, and or behavioral health settings, because they are serving the clients that are currently experiencing major social justice issues and not being appropriately receiving robust care. One of the first things that you have to do is to work to prioritize in the minds of providers the issue of tobacco and help them to intervene more easily. It's shocking to me to realize that the deaths due to tobacco yearly are equal to those of COVID in this year. It's a pretty amazing statistic. This is an old statistic, but what it shows you is that almost half of the deaths due to smoking, which are of course much greater than the deaths due to any of these other public health diseases, almost half of those deaths are due to people with mental illness, way more than the number of percentage of them in the population. Smoking is a disease, treat it. A message like this may help in reminding providers that they are dealing with a chronic relapsing condition. It is a disease, there is a treatment, and it's really important for it to be addressed at every visit. Shu Hongzhu of the California Smokers Helpline has identified the reality that there is a quitting machine. The quitting machine consists of people entering the process of quitting. They might make a quit attempt. They might relapse and go back to making another quit attempt. They might at first become a non-daily smoker and then become a former smoker. Again, they might relapse, but the more people coming in here, the more people come out here. So it's very important that providers see every quit attempt or step toward quitting as a success. It is a process, not a destination, and not to feel inadequate because the person, relapsed, because the fact that they even tried is a huge success. So when you're putting together a training for providers, the things that you want to include would be a bit about the problem, a bit about the cycle of addiction, evidence-based treatment, what does it consist of? And at the simplest level, and I really think it's important to start simple, ask, advise, refer, and helpline resources. I'm going to go through a little bit of that pretty superficially. And I want to remind you again to keep it simple, because sometimes you will only have 30 minutes with an agency. And if you've really worked with them in advance, at least you'll know what might work for that agency in terms of moving them along from wherever they are at. So you want to discuss the problem in general and locally, the health disparities, ethnic and socioeconomic issues, social justice issues, show maps of tobacco rates, very telling in our area and in most areas, I think. Talk a bit about the tobacco industry and the benefits of quitting. Then you'll want to look at the cycle of addiction. I often talk about the addiction triangle, the biological piece, the physiological piece, which is keeping people addicted to tobacco, because once they start and become a regular user, if they don't smoke for a period of time, and it can be as little as an hour, they can experience, pretty significant withdrawal effects. So that's very important in terms of what are we going to do to treat them, then the psychological and social aspects that are essential to be addressed in all of these clients. And in addition, I always talk about the circle of support, the degree to which the people they live with, work with, play with, and go to school with, if they smoke, it's much harder for the individual to quit. However, on the flip side, if they don't smoke, it's much easier for them to quit. So really being mindful about that. So a little attention to the biopsychosocial aspects of addiction, and then clarification of evidence-based treatment. And I think it was alluded to today that, and Dr. Fiore actually talked about it, that physicians are often, and other providers are often not well trained in addressing tobacco. So understanding that the treatment is a combination of medication and behavioral support, that is the evidence-based treatment, is extremely important. In terms of medications and how they work, it's important to go over how they work. I would agree with Dr. Fiore that if all they do is learn about using patch and gum and varenicline, to, that those two options, patch and gum together and varenicline, are the most effective options. And if they become comfortable with that, that can be very effective. There is a video that you can access later when you get this PowerPoint that's made by Kaiser that explains the different meds, and that can be really helpful with certain populations in terms of helping them to understand what you're talking about. The different medications, the 7 medications, are all listed here, and you'll see that the majority of them have the same efficacy in causing 6 months abstinence, or being a factor in 6 months abstinence. That varenicline is higher. And over here, what's not shown on this graph is that the patch and short acting is even more effective, but probably about the same as varenicline. And so again, trying to keep it simple, especially when beginning to work with a primary care agency, is important. True or false, vaping is an effective tool for quitting tobacco? The answer is probably not. You may have to go into that in more detail, but at this time, we're going to move on and talk about the importance of understanding. The person who's doing the training really needs to understand how the medications work, and ideally how they are covered by Medi-Cal or Medicare in another state. I'm sorry, Medi-Cal and Medicare or Medicaid in another state. And also understanding that they're generally used for 12 to 14 weeks, although they are occasionally used longer and sometimes shorter. And patients often want to use them shorter because they feel great and they do stop. And that's when they really need to be encouraged to keep going, because they were stopped because they were feeling great and now they, are relapsing. So just having an understanding about how this works is important. We don't generally go into a lot of detail about this in a very short training, but just mentioning that the factors for a brief intervention that would need to be addressed are quit date, where can you get support, what are your triggers, what are barriers, skills and behaviors you can use, and how you will prepare. Those are things that we discuss in longer, different kinds of trainings I'll get to later. Obviously, it's been mentioned today, cultural humility and sensitivity, empathy, using motivational interviewing skills, generally very helpful. Although you're all familiar with the 5 A's, this particular training suggestion for getting started is really focusing on ask, advise, refer, AAR. You'll want to find out how is the asking being done if you're working with a federally qualified healthcare center. or similar clinic, because most of them are using electronic medical records, and generally there's a procedure where a medical assistant or someone other than a provider is doing the initial asking. And sometimes it's taking it further and asking them if they would like to be referred to someone who can help them to quit, and doing an electronic referral. So sometimes some piece of that will already be in place. So when you do your training, you're going to want to know if, hey, they're already having the medical assistant doing the asking, and just reinforce that it's really important that that be done at every visit, and that they be offered an intervention at every visit. Getting that into policy can be extremely helpful as well. The advice needs to be clear, strong, and personalized. I particularly like personalized. Continuing to smoke is going to, aggravate your asthma. It's going to make it worse. Quitting can dramatically improve your health, and we're here to help you. So many different options of how that can be done. And then helping people to be familiar with the resources of the California Smokers Helpline, which has not only over the phone counseling now, but many other services, web chat apps and text services. It's available for teens greater than 12. You heard a lot about it earlier. One thing to note is that they are specialized in tobacco treatment and behavioral health. So half of their callers are people with behavioral health conditions. That's been documented. There's a wonderful video here, again, you can access when you get the PowerPoint, that can be helpful to clients to explain how quit lines work. And that is actually, available online, and you can, if you have the facility to do it, have it be available in the waiting room for clients to listen to. This kind of reviews an example of a flow chart. How the clinic flow is extremely important in doing any training. This comes directly from Dr. Tong's California Quits Toolkit, where there are a number of different options, but reviewing the flow during a training is important. So the patient presents, if they're not a tobacco user, you're done with them. But again, here, the medical assistant is the one who did the screening. She puts that information into the electronic medical record. If the person is a tobacco user, the medical assistant often offers the helpline. And if they're not interested, then hopefully the provider will go on with some things we'll get to. If they are interested, again, hopefully the provider will go on, but the medical assistant may be able to submit the referral through direct e-referral. Now, the work that we have done has included working with agencies to get that online. So it's not, to my knowledge, online with any of the existing direct referral. Is not, it's available, but not for referral to the helpline. And that involves a pretty complicated procedure in working with the helpline to do it. Again, it's IT heavy, and it costs money. So sometimes you'll be working on that. Sometimes perhaps it's already set up. Anyway, once that's done, then the patient is proactively contacted, and later the helpline can send an outcome report to the health system. This, unfortunately, has to be even more streamlined for the information to get back to the provider, which in the best of all worlds is where it's going to go. So just to give you an example of what this might look like, here is a electronic medical record screenshot, and the order is added. And then what happens is that you'll see that there's a place where it says, okay, there's a referral to the helpline. I know you can't really see this, but I'm describing it for you. And then there's a place for them to put in the appropriate phone number for the person and to document that the person has given consent. So this is in the best of all worlds, what happens alternatively, fax referrals can be done, electronic referrals can be done, but that is a sort of out of the existing flow. So it may involve another person. Do you go back to the medical assistant? So it is more complicated. Anyway, in terms of discussing, well, what happens if the person says, I'm not ready? Then the language can be discussed. You're not ready to quit right now. That's okay. You're the only one who can make a decision to quit. We'll be here for you if you want to talk about it in the future. That's one option. Another option is when the person is ready to quit and they're referred to the helpline, which we already went through. A third, which I think is worth mentioning, but probably not dwelling on, depending on how much time you have and how motivated the participants are. If the providers are willing, asking an open-ended question like, what are your thoughts about quitting? Or another open-ended question can be really, really helpful. So that can generate a conversation like, well, you know, I know I really need to quit because of my heart condition. But I'm so stressed right now, I just don't think I can. And that tells you that there's some interest on the part of the patient. So trying to get that going is a really good idea. Ask, advise, refer does still need to have some attention to medication. So perhaps it should be ask, advise, assist, refer, but some people call it ask, assist, refer. In any case, just remember that medication may be necessary if it's not going to be provided for the entire course by the helpline, and our 2-week course is not a full course of medication. So you've talked about the problem, the cycle of addiction, evidence-based treatment, ask, advise, refer, helpline resources, and then you want to monitor and provide feedback. So let me make the case briefly for behavioral health addressing tobacco. Joe Geidish initiated talking about this earlier. Keep in mind that addressing tobacco in behavioral health is very consistent with the mission. Yes, it's been pointed out that we are fortunate in California with its low rates of tobacco use. However, that is not the case with our behavioral health population, as he stated. And we know that if you do not have a mental health problem, the chances that you smoke are 22%, 35% if you have a history of a mental health problem, 41% if you have an active mental health problem. And the more mental health problems you have, the higher the rate of smoking. The short of this slide and the next slide is that in a 2018 morbidity and mortality report of smoking rates in psychiatric mental health facilities and substance abuse facilities, and what you're seeing here is California's rates. We were below average on screening, providing cessation counseling, providing medications, and smoke-free campuses, below average. In other words, there were programs that were up here. So this is true for both our mental health and substance abuse interventions. It is embarrassing that California is in this situation. It's particularly embarrassing to me because I've worked on this for many years, and I've seen, progress, but I've also seen some of the barriers that occur around this. Here's the good news. Any of you working in California, there is a bill that's going to begin to make a dent in this. AB 541, it will assess tobacco use in all substance use patients and inform them how continued smoking can affect their recovery, recommend treatment for tobacco in the treatment plan, and require agencies to offer treatment or referral to treatment for tobacco. It's just a little step, but it is currently in the legislature. Hopefully we'll get through the legislature, and it will actually be a potential entree for those of you working with or wanting to work with behavioral health agencies. So there's differences when you're dealing with behavioral health agencies compared to when you're dealing with primary care agencies. about addressing tobacco. And you already know that there are high rates of smoking. What you hopefully know is that research has shown that when a person in drug treatment is treated for tobacco, they have a 25% greater chance of being free of alcohol and drugs a year later. So it helps them to be able to stay quit. And there's some very good reasons for that. There's no evidence that quitting does cause relapse to drugs or alcohol. And the leading cause of death in recovering people is tobacco. So here's the most important issue, and again, why it's part of the mission. Tobacco has been incorporated routinely into the use of other drugs and serves as a trigger to return to other drug use, and basically traps patients, participants in drug treatment, in harmful coping. So the mental health claims, there are some other factors that are important, that smoking cigarettes changes the blood levels of some psychiatric medications. As a result, the patients need to have their dose decreased, usually several weeks after quitting. And without knowing that and acting on that, they may be overdosed when they try to quit, and that can lead to failed success in a quit attempt. So that's an important factor. It can also be a motivator because a lot of these patients want to be able to take less medication. It looks like the atypical neuroleptics are much better than the older ones in helping people to quit smoking when they have mental health conditions and are on medication. People with schizophrenia may actually be helped by short-acting nicotine replacement initially, but they don't need to smoke. It is not the cigarettes that may be helping with some of the aspects of schizophrenia. And most of the people who transition to this can transition off the medication, but it may take a lot longer than with some of the other individuals. And we've already mentioned that it's a major contributor, probably accounts for at least 40% of that 25-year mortality gap for serious mental illness, and again, is the leading cause of death. Not widely known at this point is the fact that when people quit smoking, it tremendously improves their quality of life. The psychological quality of life and positive affect go up, and anxiety and depression go down, and stress goes down. And the stress factor, this is after usually maybe about 3 months. The stress factor has been recognized before, but some of these other issues have not. In fact, the improvement in depression is at the same level as the improvement in depression seen when a person takes an antidepressant. So it's a really remarkable effect. When people quit, their health improves, job opportunities improve, they have better housing options, more money, less addictive behaviors, lying, sneaking, and stealing improve. And this is seen even with tobacco. More time, 140 extra minutes per pack, less stress, improved mood, potential for less relapse to substance abuse, and more people want to be around you. These things happen over time, and this is like it's like a person's work with a case manager to help them to have a better life just by quitting tobacco. What to include in behavioral health tobacco training? You want to talk about what currently exists at their site, the concepts that we just reviewed about importance and relevance. You'll want to have them look at a tobacco use assessment. I'll show you where you can find an example of that in a few minutes. Staff are already trained to do this work. They're usually very good at motivational interviewing and cognitive behavioral counseling. And so integrating tobacco treatment into behavioral health is kind of like a natural. Now, they're not knowledgeable about the medications. And that is something that we all have done a lot of training about, and tried to figure out systems when there's not a provider available to help agencies to be able to get patients started on medication. So in addition, there's a need to look at the workflow and what is possible to help them to be able to get tobacco treatment medications for their patients. So I'm going to stop here and just say that there are a lot of challenges in this work. But before I go into them, I do want to say that most of the work that we've done with agencies, where we had about 17 agencies become tobacco-free, most of them did it over a period of time, developed a policy for being tobacco-free, and were tobacco-free from the perspective that not only were the staff learning about tobacco treatment and providing it to the clients, but also that staff and clients at the residential agencies were expected to be tobacco-free, and at the ambulatory agencies, the staff were expected to be tobacco-free. And that is not obligatory, but it is desirable, and it's something that I view as the ideal. So I just want you to have that information as background. And one of the things that helped us immensely was the good relationship that we had with the director of behavioral health, and the fact that they had to come up with policies, and they had policy guidelines initially, but those were later converted to pretty solid policies that all the agencies were to adhere to, that did everything except require. They encouraged agencies to have tobacco-free sites with no evidence of tobacco use by staff, and also by clients in the residential settings and ambulatory settings, but there obviously patients can leave and go smoke. So some of the challenges in all of this work are lack of time on the part of trainees and high staff turnover. One of the things that helped us with that was, being able to do frequent trainings over time, and different types of trainings, so that and we were able to do group trainings at a behavioral health site that were made available to people from both primary care and behavioral health, and kind of covered both topics, and were often 3.5 hours. Workflow and implementation varied from site to site, so you have to find out about that. And what I learned was that we're in a site where, when the supervisor says you have to do it this way, everybody does it that way. Your program that you're trying to implement works a lot better than when there's not automatic following of the guidelines. And so that's something that I'm sure will exist everywhere. There are a lot of staff myths about treating tobacco that are rooted in the culture. AA, which is a wonderful program, and there is a Nicotine Anonymous that can be a good resource, especially for people that are already familiar with 12-step work. However, both of the founders died of tobacco-related diseases, and there is has been a culture of, don't try to do anything else, just quit alcohol. So there is that. Then there's tobacco industry myths about things like you have to smoke if you're a schizophrenic. It will help you, and also that schizophrenics are immune to lung cancer. And staff smoking in substance abuse and mental health and behavioral health settings is high. It actually increases as a function of how intense the agency is. So your residential substance abuse treatment programs have higher rates of staff smoking generally than the ambulatory ones. That can be kind of a double-edged sword. Sometimes you'll get support from people who smoke and or have been smokers, and often, and sometimes, depending on the number of smokers on staff, it can be a challenge to move forward with staff having no evidence of tobacco use at work. I personally have an issue with the term cessation when working with behavioral health care. I prefer to use the term tobacco dependence treatment or tobacco treatment. And it has to do with the fact that it's setting up a separate, unequal arrangement where the basis of the addiction is very similar. And I just think it's more consistent with the language that people are familiar with. So just something to consider. In California, it's challenging to access nicotine replacement therapy in residential substance use programs, and special arrangements have to be made to make that work. I think that may be improving, but what I mean by that is most of them don't have a medical staff person on site. And so there's not a person to do a prescription when the person walks in the door, if it's a residential program. And if it's going to be a tobacco-free program for the clients, they need it when they walk in the door. So they will not get bogged down with withdrawal. It is also a bit challenging for drug medical programs to have, especially the ambulatory ones, to get paid for their work on tobacco interventions. And hopefully this is something that may change. Possibly the bill that I mentioned to you will help to bring about some change with that. Again, that's unique to California. My understanding is that it's not the case in some other states. And there are unexpected challenges with the electronic medical record systems. I mean, it was really challenging to work to arrange that NextGen, which was being used by all of our local FQHCs, was had direct messaging to the California Smokers Helpline, and then all of the agencies switched from NextGen to Epic. And then you have your lead time to get it, the new medical record. People get used to that, and then to have the referral to the helpline included. I hope that the electronic medical record systems are going to start making arrangements for that as part of for referrals to the helpline as part of their systems. But right now you have to do a workaround. We did have the experience of some established successful programs being defunded in spite of advocacy efforts. And that was, hard to deal with, but I think it sometimes happens, and, money's gets moved around for many different reasons, as we know. Patients believing myths about medications. This is an interesting one where a lot of patients are afraid. They don't think that medications work, especially the nicotine medications. They may think that. There's also a sentiment that goes back, many, like 20 years, that nicotine patches will make you have a heart attack or possibly cause cancer. All of our literature, and we have extensive handouts on the medications, say up front, this medication will not cause cancer or cause you to have a heart attack. I do believe at this point that we probably need to do more working with community representatives to help them to become knowledgeable about the medications and get the word out. That is not something that I had a lot of experience doing, but increasingly I believe it's important. I want to talk briefly about the staffing that the program had, just so you can have a feel for it. It was about 1.7 FTEs. We were, had to get funding kind of repeatedly every 3 to 5 years, but have been funded by initially public health and then public health and behavioral health, now into like the 22nd year, which is very fortunate for us in terms of the benefits of continuity. And what that funding consisted of is a part-time physician director consultant with primary care and substance use experience, a full-time project manager who managed the outreach and follow-up and coordinating contracts and grant writing, a part-time assistant, a coordinator who did work with data and materials design and everything else that we needed. It was, I believe, an asset for staff to be trained as tobacco treatment specialists, which was able to happen in a couple of years ago when we had new staff. Some staff or a consultant with experience as a primary care provider or a behavioral health provider is extremely helpful. This was alluded to when Dr. Fiore talked about the researchers not needing to learn a lot about the electronic medical record and other things, because it's helpful because the person knows the jargon and also knows about medical records. And the electronic medical record can be an influencer and an advocacy voice. And we had a lot of experience with that. The work that we did, now we'll switch from challenges to strategies that can be helpful. The work that we did with leadership of the organization, the behavioral health organization, to develop their commitment was extremely helpful. Probably the best thing that happened was that this bureaucratic agency gave us a liaison, and that person would bring people to us at monthly meetings for us to work through issues or concerns, and really helped us with policies, with getting cooperation with surveys and issues like that. I sometimes reflect that maybe we need to do more of that with the primary care intervention work that we are doing. And working together with new initiatives helped us a lot. And examples of that, we're working with the 10 by 10 campaign, working with the co-occurring initiative, working with CEASE. So trying to piggyback on something that's coming down the pike at agencies that you're working with can be really, really helpful when you can find a way that it links to the work that you're doing. I did have experience with one agency that did a tobacco registry, and I found that to be very enlightening, because basically what they did was have a staff assigned to outreach to all of the patients who had been prescribed some form of tobacco treatment or who had been referred to the helpline. And what came out of that was the realization that there were a lot more patients that had quit than had made connection with the helpline. And that's not to criticize the helpline in any way. It's just that if all you look at is who's getting to the help, who's being referred to the helpline and who's actually connecting, you won't see people that are also getting these other interventions and having some success. So I think it's something that needs to be further explored, and the electronic medical record allows you to identify people who've received medication and or been referred. So other strategies that can be helpful, looking at HRSA data to see how are people doing with tobacco, working with tobacco champions and ethnic champions. We've worked extensively and gratefully with Valerie and Carol Magruder and Phil around menthol and menthol issues for years. And that's been very exciting work. Working on establishing policies over time will help, because when the tobacco champions leave, which they often do, then the policy is still there. We have some good examples of that. Medication elaboration, just really understanding the medication and some of the problems that come up with it is something it's important to train people on. And pharmacy advocacy, we were able to be part of advocacy. Whoa, oh gosh. let me stop here and see if there are any questions.